Kelly introduced me, my name is Ashish Rawal. I'm a board certified orthopedic surgeon. I've been in practice nearly 20 years, of which the last 11 have been here in almost 12 in Wisconsin. Um, Most of my practice now is involving knee and shoulder care. Still do some hip, but my partner, Dr. Henningsen, does majority of hip care, which allows me to really dive deep and take care of the things that I really do well, which is knee and shoulder. And this talk is going to be specifically about shoulder issues, which is a passion of mine. The OrthoTeam Clinic and who we are. We're a legacy practice that has been in the Madison area for over 40 years, and that and then also became part of Stoughton Health some years ago. So we have a rich history, and with that we have two locations. One at Stoughton Hospital at our new um, outpatient ambulatory care center, which we just opened last year. It's a beautiful 56,000 square foot facility that gives us, access to large clinic space to see patients, as well as a large rehab therapy area as well. And we're bringing more and more services and options for patients there as well. Additionally, we also have a second office in the Research Park area on the west side of Madison. We're able to see patients both in person and in telemedicine. Here's just some information about our website and a phone number. And the fine print that I always have to include is that everything we talk about here is just meant to be information. It's not meant to be medical advice that you should use to take care of yourself. Hopefully, this gives you information that you can then use with your medical provider to be able to get you some help. And then last, although this is information I'm giving to you, um, obviously you can share this and have your care with the provider of your choice. We're always happy to see you, but there's many good medical care providers in our area, and they all really do a good job. This is meant to be informative in nature. All right. So let's go on to our next slide here. This is just showing if you go to our website, orthoteam.com, you have ability to request an appointment there if you choose so. All right, let's talk about shoulders now. Um, so shoulder pain is something that is really prevalent. And we can see, by the fact, that there's, I think 70 something people signed up to be at this talk. It's a problem with shoulder pain I've had throughout my life that's come and gone, and obviously we all encounter it just because we use our arms and shoulders every day, and it really isn't until you have a shoulder problem that you realize that it can be really debilitating. Not only are you able to do your normal daily activities, you're not able to do the things that are fun, and also I think the toughest part for a lot of people is they really lose that ability to sleep, and that I know if you're anything like me, if I don't get sleep, I become really crabby. And so, sleep is important, and shoulder pain can really affect that. Now, when we look at shoulder pain in general, there's two main categories we're going to look at. One is acute pain, the other one is chronic pain. And as the name kind of implies, obviously, acute pain is something that happens suddenly. It can happen from an injury or a fall. And the opposite is chronic pain, something that's been going on for a long period of time. It's slowly worsened over time, and there may not be any specific injury that caused it. However, there may be repetitive things that are done on a daily basis that can contribute to it. When I like talking about shoulder issues, I really like defining them by kind of four major categories: pain, stiffness, weakness, and unstable or instability of the shoulder. And pain can be part of all of them, but sometimes it's its own kind of separate category. The first question we always have to ask ourselves, and when I see patients, is, are your daily activities limited? Are you having difficulty doing simple things like brushing your hair, putting on your seatbelt in the car, reaching for a shelf, getting your clothes on? Those are things that can be really debilitating, and when you can't just do those basic things, life can get pretty rough. And then the next level is, besides the things that you have to do, the things that you want to do. The activities that you may be doing on a daily basis, whether that's golf or tennis, like we see in these pictures, but other things that may bring you joy, whether that's playing pickleball with your friends, playing catch with your kids or your grandchildren. Those are all important things, and really are at the heart of the quality of life that all of us really desire. And if we take a look at the shoulder, it's a pretty complex structure, but if we break it down, there's two major bones that kind of make it up. One is going to be the shoulder blade, and the edge of the shoulder blade makes up the socket, which we see here, called the glenoid. And the other side of the shoulder is the ball side, which is the top of the humerus bone. Whoops. And those two together, when they move, give us motion in our shoulder. The other part that we talk about less is actually the other part of our shoulder that will also move, is where our collarbone, our clavicle, joins the roof of our shoulder here, the acromion. There's a motion in that joint. And the other area is your shoulder blade itself. It sits against the back of your chest, and actually all the muscles that attach to your shoulder blade, your shoulder blade moves obviously when you move your shoulder around too. So there's a lot of different parts that move, and it's not just the ball and socket, but the most of the motion does come from that ball and socket joint. Seems like my computer's possessed today. All right. And then on top of the bones there, we're going to see ligaments, and then on top of that, we're going to see what we call the rotator cuff. And many of you have heard that term. And what the rotator cuff is a series of what starts off as muscles, which we see the red here, that then turn into tendons, which are thick, flat ropes, which then attach to the bone itself. So in the rotator cuff, the muscles start on the shoulder blade, and then they end on the humerus bone itself too. And the reason it's called a cuff is it's kind of like a cuff on your sleeve, where it wraps all the way around. And so our rotator cuff is in the front of the shoulder, the top of the shoulder, and the back of the shoulder, making it a cuff. Some of the main causes that we'll see, and I think mainly for our talk, there's going to be, um, I briefly mentioned unstable shoulders and instability. And although those may occur in, shoulder dislocations, like I mentioned here, that's probably not going to be most of our talk today. We're going to focus on the top one, which is rotator cuff disease, and the bottom one, that is arthritis. But I'll mention all of them briefly. So with rotator cuff disease, the most common tear we see of the rotator cuff is what we see right here on top. The rotator cuff on the top here, called the supraspinatus, that can tear away from the bone and maybe just leave a little bit of the tendon there. But that tear then can cause pain and weakness for a patient, and can cause significant dysfunction. And just for definition purposes, that's what that looks like. Next is a shoulder dislocation, and what can happen there is the ball actually comes out of the socket. That can happen in different ways. For young athletes, that can happen playing sports, where it can come out. And as we get older, we'll notice that it may also come from a rotator cuff injury. If you have a large enough rotator cuff tear, then your shoulder could become unstable, and you can have potentially a dislocation. Fracture is another thing. So broken bones, when we do see fractures around the shoulder, the majority occur right below the ball, kind of like we see this break, this line here. And luckily, many of those can heal up well without needing any surgery. And so we're going to leave that part alone today, and talk about the other parts I mentioned. And the last part that we are going to talk about more is arthritis. And what is arthritis? Arthritis is the loss of cartilage, which is the nice smooth lining on top of the bone of the ball and socket. So when those are nice and smooth, it's like two, nice ball bearing or a nice joint that moves really well, versus when it's arthritic, it's like two pieces of sandpaper rubbing against each other. It's a really rough surface, and obviously that can become very painful for a patient. So how do I diagnose this, or how does anyone diagnose any shoulder problems? Well, the first most important thing is talking to the patient. Many times, if you talk to them, they will explain what's going on, and you can figure it out, pretty straightforward in terms of that. There are going to be some complex things that can be difficult, but many times I find if you let the patient talk long enough, they will tell you exactly what's wrong with them. But we do use other tools besides talking to the patient. Obviously, examining them is very important. So, from a good exam of a shoulder, I can also um, be able to deduce what's going on. The other things that we will use commonly are x-rays. Sometimes a CT scan or an MRI is very helpful. CT scan is better at looking at bones. MRI is better at looking at soft tissues like the rotator cuff. Another way that's very popular and growing is ultrasound. And ultrasound is a way that's non-invasive to be able to assess for injuries such as rotator cuff tears. The most important thing about ultrasound versus the other technologies is that they are very much user dependent. So it really depends on the person doing the ultrasound, what type of information that they can get. So, what are our short term treatment options for most shoulder problems? Well, one is lifestyle change. Hopefully temporary in nature, not permanent, but maybe we need to back off what we're doing or change what we're doing. Maybe the form that we hit the golf ball isn't right, or maybe our grip on our tennis racket isn't appropriate, or maybe we're throwing the softball or baseball too many times. All the simple things that we do, maybe a slight change in those activities can make things better. Another common modality is physical therapy. And physical therapy can really help do things the right way and use your shoulder the right way, rebalance muscles, use better mechanics. There's a lot of things that physical therapy can do. And for a lot of patients, it's a great option that we recommend many times before we even consider doing surgery for a patient. Medications are helpful. The mainstays are going to be medications like Tylenol, ibuprofen. Obviously, we stay away from narcotics in general, unless we need them after surgery. Injections are very helpful as well too. And they come in different flavors. The most common one that we're going to use in the shoulder is a cortisone injection, which is a steroid. It acts like an anti-inflammatory, meaning it's like a fire extinguisher that we're using to help put out the fire. In some cases, the fire extinguisher may be big enough that it puts out the fire permanently. In some cases, it's not a big enough fire extinguisher, and the problem after some relief may persist. Many patients, when they talk to me, they say, listen, I don't want to do an injection because I don't want a temporary fix. And although that's a reasonable way to think about it, I would ask that you think about it as being a potentially a permanent fire extinguisher, because for some things, if it can really calm down the shoulder, then things may be able to heal by itself. So, and sometimes it can be a permanent solution. So I do ask patients, keep an open mind about it, because it really can be beneficial. Now, rotator cuff injuries are a really common problem. Our information tells us that at least 2 million people a year go see a doctor because of a rotator cuff problem, and that's just in the United States. So it's a very common problem. Not only in my office, but primary care physicians' offices, emergency room, urgent care, physical therapist, chiropractor. They all see these, so it's a common issue. And the interesting thing is that many people will even have a rotator cuff tear and may not even know it. So the information on the screen here says that after age 60, potentially 40% of us are walking around with some type of rotator cuff tear. And many don't have any symptoms. And so the main point I'm trying to get across there is that just because you have a rotator cuff tear doesn't mean that you have a problem. And just because you have a rotator cuff tear doesn't mean it needs to be fixed or you need to have surgery for it. So not everyone needs surgery. And there's a lot of extra factors that we look at in terms of making that decision. Um, Many times, if they're smaller tears or tears that have been there for a long time, or in someone who's um, has low overall function, or it's not bothering them at all, we definitely want to consider conservative treatment options, physical therapy, ejection, etc. The things that do help us make those decisions are patient's age, the size of the tear, whether it's been there a short period of time or a long period of time, and their overall health, and other things like smoking, diabetes, etc. It's important to note that sometimes, although the rotator cuff may be torn, there may be other issues in the shoulder that are causing pain, including the biceps tendon, arthritis of that small joint on the top of your shoulder where your collarbone meets the roof of your shoulder. There could be other issues as well that could be going on at the same time as a rotator cuff tear. So let's say all those options have been exhausted and someone was really suffering quite a bit from a rotator cuff tear. What do we do to address that? Well, as this picture shows here, the goal is to basically, put stitches in that torn rotator cuff and re-anchor it back down to bone. Now, there's two parts to this for it to go well and patients to have a good outcome. One is surgeon being able to fix it and repair it, put it back where it needs to be. But the more important part is that the patient's body then is able to heal that tendon back down to bone. So these stitches and anchors aren't meant to last forever. They're meant to just hold things in place until your body can heal it down. And sometimes without surgery, it doesn't have the ability to do that. So just for example, say you get a big cut in your arm and there's a big wide gap of a couple inches. Well, that's never really going to heal on its own unless that gets stitched shut. But remember, when you get that stitch shut, the, those stitches aren't meant to stay there forever. Your skin edges will heal over time, and then those stitches come out in a couple weeks. Now, in the shoulder surgery, we don't go back and take those stitches out, they stay in there forever. But just remember, a lot of it is your own body's healing that back down to bone, and having that right biology and environment for it to do that. Now, there's different ways to skin a cat, and how do we repair that back down to bone? Well, traditionally, we used to do what are called open repairs. Make a big incision on the shoulder, look right down at the rotator cuff and the bone, and then reattach it. The evolution after that was we would look inside with a camera, say, aha, we have a rotator cuff tear here, and then make a little bit smaller incision and then fix that back down to bone. But in 2026, the gold standard is an arthroscopic repair, meaning we do all the work through small incisions using cameras and small instruments to do it. So there's not any big incisions on the shoulder to do that. So arthroscopic repair gold standard in 2026. I'm going to show a little video here that shows how this is actually done. My computer cooperates here. All right. All right. So this is a right shoulder. And what you see here, all these little tubes are what allows us to have access inside the shoulder. Here's the camera looking from the back, and here's a tear of the rotator cuff. And I want to be able to attach this back down to bone. So it requires preparing the bone. And then next, we're able to place some holes in the bone, which we're going to put these anchors in. Now, there's different size anchors, but most of them are pretty small. This may look large, but it's only 4.75 millimeters. So pretty small overall. So less than a quarter of an inch. Um, those have a stitch coming out of each one. And we have a special device that we're able to use to sew it through the rotator cuff. So we're going to see that now. And that gets sewn through there and passed. And through these other tubes, we can pull stitches in different places, um, and so it's kind of like building a ship in a bottle. Now what we're able to do is in this specific example, there's different ways we do it, but we take the stitches from one of the set of anchors and then pass it over the top and then anchor it down to the bone. It's kind of similar to um, at Christmas when you're bringing your Christmas tree home, you throw it on top of the car and then you take rope and you zigzag across the top to hold it down in place so that way it doesn't end up on the side of the road on the way home. In a similar way, we're basically um, using these stitches and these anchors to repair and mat this back down so it's in a good spot so it can heal on its own. Here we show just if we need, we can always put extra stitches if we need extra support. And then here's the last anchor going in. And then when we're all done, we can see these stitches zigzagging over the top, holding that rotator cuff in place. So this is kind of what it looks like now. This is just one way to do it based on the size of the tear. Sometimes if tears are smaller, we need less anchors. If tears are bigger, then we use more anchors. And that's just showing a tear of one tendon. Potentially four of them can be torn. So it may require more work. Now in 2026, another thing that's really popular as well is, we talked about the biology of healing your rotator cuff. So, like I said, it's not just about the surgeon being able to repair that, it's about will the tendon heal back down to bone. So we know there's going to be certain cases where we have large tears or they're older tears or there's more muscle atrophy where we may need a little help. And so in 2026, we have a lot of different biologic devices that we can place, on top of the rotator cuff repair. These are ones showing, different companies, products. And I call it's kind of like Miracle Grow. It's something a little bit extra that we can put on top of the rotator cuff to help it heal. Now, it's not for everybody. It's just for the ones that we are more concerned about that they're not going to heal. And what I do is there's specific calculation that I do prior to surgery by looking at the MRI and looking patient's information, and that gives me a score. And if the score is above a certain number, then I do want to add something to the repair. If it's below a certain number, then I'm pretty confident that it's going to heal with just a standard repair. But in 2026, we do have a lot more options available. This option here that I'm showing a superior capsular reconstruction is something that we used to do 10, 15 years ago. It was kind of using a cadaver patch to kind of act like the rotator cuff. Um, it did not really work that well, but some of the ideas that came from it have worked well. Another option is what we see here. It's called a balloon spacer. And basically, in someone who may not have a rotator cuff that can be repaired, but they have significant pain, we can place this device that's kind of a balloon that we fill with saline, and that helps put the shoulder in a better position to help alleviate pain. And that can be done through a quick surgical procedure. And again, it's not for everybody, but it's an option for the right patient, and can have really excellent results in the right person. We're going to skip that video. And then another option that we see here, this is a view from the back of the shoulder, is in some cases where we have a large rotator cuff tear that cannot be repaired, we can do tendon transfer surgery. In this case, what I'm showing here is what's called a lower trapezius tendon transfer, where we're basically borrowing another tendon and muscle to act as the rotator cuff. And again, that's another option in 2026 that's helpful. In the past, if we had patients who had a really large rotator cuff that wasn't able to be fixed, or maybe they had a repair before that had failed, many times we just shrug our shoulders and say, listen, sorry, we don't have an answer for you. Maybe in another 10, 20 years, you may need a reverse shoulder replacement, but right now we don't have any option for you. Well, these options that we're seeing with the balloons and tendon transfer surgery, et cetera, are these new options that are filling these gaps and giving us options that we never had before. So um, it's amazing the amount of advancement that we've had in shoulder surgery. So that's rotator cuff. Let's focus a little bit now on shoulder arthritis. Remember, shoulder arthritis is that loss of cartilage, the nice smooth lining, and then with that, what patients are going to have is, not only pain, but stiffness as well, and they're not able to get their arms overhead for a lot of activities. And believe it or not, in terms of treatment for it, surgery that we do, shoulder replacements, it's the third most common joint that we replace. Everyone knows about hip and knee replacement. Not as many people know about shoulder replacement, but it is a great option. Um, Shoulder arthritis is very different from knee and hip arthritis, and the easy explanation is we don't walk on our arms. And so with shoulder arthritis, what a lot of people will do is they start developing arthritis. Because of that, they have pain. And when they have that pain, they quit using their shoulder. And that leads to more stiffness, which then leads to more pain. They use their shoulder even less. So many times, patients come in, they're basically living with their arm just at their side. They can't do anything overhead, and they kind of just live their waist below and don't do anything overhead. Well, now, if you had that same type of problem with your hip and knee and you couldn't walk around, you'd probably be going in to see somebody sooner. But shoulders tend to go a lot longer before a patient seeks care for that. We know that shoulder replacement is a safe, reliable surgery that helps restore mobility and help improve pain. And a lot of research has shown that most patients, the vast majority, are very satisfied and have significantly less pain, if any, after shoulder replacement. So the main option when we look at shoulder replacements, one is what we call an anatomic shoulder replacement. So that's kind of what you see in this picture. And with that, by anatomic, we mean we replace the ball with a new ball and we replace the socket with a new socket. And then what that allows us to do is basically replace that rough, unsmooth joint with a nice smooth joint. And as you can see in this picture, not only is there a new ball, but the prosthesis goes down into the bone, into the humerus bone, which is hollow inside. And we machine that so that way that prosthesis fits in there. Now, this version that we see here is kind of a short stem. If we look at what we potentially did 15, 20 years ago, we used longer stems that went way down deep into the bone. And now we have these shorter stems, and I'll show you some of the newer advancements as well. But here's kind of a close-up version of that. You see new ball for the ball, and then this plastic socket is the new socket. Well, the newer advancement we see is what we call stemless shoulder replacement. And what that is now it's a much smaller part that goes in the bone. You don't have a big, large prosthesis that goes in the bone. And then with that, potentially there's less pain, a little bit quicker return for patients. And so that is also a very great option in the right patient as well, too. And then even less bone removal is done with what we call a stemless resurfacing. So instead of removing the ball, we're putting a cap on top of it, which we see in this picture in the top left, and then the new plastic socket as well. And that's also a very great option for the right patient. So a lot of different ways to skin a cat. Another newer option that's really been great over the past few years since it's been FDA approved in the United States is what we call a pyrocarbon hemiarthroplasty. Now, that's a lot of words. And what is this and what is it for? Well, pyrocarbon refers to the material coating on top of the ball. Now, traditionally, the ball material is made out of cobalt chrome material. And before we used to do full shoulder replacements where we replace the ball and the socket, we used to just replace the ball. And the problem with that is that when you have cobalt chrome rubbing against someone's own natural socket, it can cause a lot of wear of that socket. And over time, that can become a problem. Um, Another problem that we also face is that, oh, excuse me, when we do a normal shoulder replacement where we replace the ball and the socket, for an anatomic, if we do that in someone who's young and very, very active, the risk is that that socket will loosen over time. And so many surgeons in the past have been very reluctant to do a shoulder replacement on someone maybe who's a 40-year-old weightlifter who wants to go back to doing all their activities because there's that risk that that socket may loosen. Um, and I had that conversation many times over the years with many patients who were really doing a lot of heavy duty work, whether it was labor work or if they were farmers, etc. So this idea of a pyrocarbon hemiarthroplasty, by this special pyrocarbon coating on top of the ball, it tends to not cause the same wear issues on the socket. And when you do this surgery, you don't replace the socket, so you don't have to worry about the socket loosening over time. So what we have seen in the experience of many countries, probably the best experience has been the data over over greater than 10 years in Australia, where they've really seen great success with this prosthesis, where they're able to do this half shoulder replacement without replacing the socket, and then allowing people to go back to full activity with no restrictions whatsoever. And so people who are really active can stay super active. And I've found in my experience, and I've used it selectively in younger patients who are really high activity level, it has really been a game changer and has allowed me to take care of patients who traditionally in the past I would have said, well, sorry, we need to wait until you're a little bit older. And they would have to just stop doing what they were doing until they got older and be able to do things. But this has really been a great option. So just like we talked about with rotator cuff surgery, with shoulder replacement surgery, we're filling in these gaps where we didn't have answers before. And this pyrocarbon hemiarthroplasty is a great addition to that armamentarium that we have. So here's a patient who came in here, and we've taken out her identity, but she let us use this video. This is her 6 weeks out from a pyrocarbon hemiarthroplasty shoulder replacement. So I'm going to play the video here. So you can see here just 6 weeks how she had pretty good function right off the bat, and we've been seeing these results with a lot of patients. So really promising technology. All right. The other technology that has really changed over the past 20 years is, what do we do with patients who have arthritis, who happen to have arthritis and a torn rotator cuff? And for those patients, standard shoulder replacement will not work. So we have this device called a reverse shoulder replacement. And it's called a reverse shoulder replacement because in this, we put a ball on the socket and we put a socket on the ball. We flip things around. And by flipping things around, one, it keeps things stable. But two, in someone who doesn't have a rotator cuff, this type of device allows you the other muscles of your shoulder, mainly your deltoid muscle, to help power your shoulder. And so it tackles two problems. It addresses arthritis and it addresses someone who doesn't have a good functioning rotator cuff. So this was FDA approved in the United States in, um, I believe it was 2003 or 2004. So it's been about 22 years that we've had it. It was developed originally decades ago in France. And over the 22 years we've had it in the US, we've made great strides. Early on, there was a large learning curve. Complication rates were high back in the early 2000s, but now, most of that has really gone away. And I believe it was 2018 where actually was the first year in the US that there was more reverse shoulder replacements being done than anatomic shoulder replacement. So it has really picked up steam, and it is a really good, reliable surgery for the right patient. So this here we can see kind of side by side, the anatomic on the left and the reverse on the right. And the interesting thing is that for most manufacturers that make these type of prostheses, they make them convertible, meaning that if someone were to have an anatomic with this stem in there, and then they were, let's say they had an injury in a fall and they tore the rotator cuff and now they needed a reverse shoulder replacement. Well, you can swap out the parts. You can keep the good stuff that you need and swap out a few parts, and then that anatomic shoulder replacement can be converted to a reverse shoulder replacement. So it doesn't necessarily work all the time, but I had some great opportunities to do that in some people, and it's worked out great. Another big part that we do in our planning for this type of surgery is we use a lot of computer CT technology. So the patient would get a CT scan done prior to surgery, and then this creates a 3D model in the software. And then with that, I'm able to take a look and see how bad the arthritis is, where they may be missing bone, what type of deformity they have. And then on the computer program, I can place all the components where I want, make sure that um, I can get them where I want them to be. And then with that, I'm also able to, if needed, create 3D printed guides, custom guides. So that way, that allows me to put uh, the components in exactly the way that I plan them to. So if I play this video, you can kind of see a little bit. Excuse me. Um, Here, just a demo one, where I'd plan it out, or for an anatomic um, shoulder replacement, we'd go in. Here on the left, we see the socket, and I'm able to spin and move that around. And the green that you see is kind of where I've virtually placed the new socket there. And I'm able to see that it's in a good position, but I'm able to move it. I'm able to say, okay, I need to move it in front a little bit, back a little bit, up or down, or tilt it. And then I can also do the same with the prosthesis on the ball side. So here we see kind of a preliminary look at it, and then you see all this extra bone. These are all bone spurs here that we would remove, but it allows me on the software to position it right where I want to, and then determine, hey, what's the right size. So it allows me to do a lot of the planning before I ever set foot in the operating room. And that way that I know exactly what my plan is going to be, and that I only need to execute it and not kind of have to make too many decisions on the fly. So it's kind of like, for a airline pilot, they have a flight plan before they take off, so they know where they're going, and then they have the part they have to fly the plane. Not that that's easy; that's really difficult, but they don't have the guesswork of just getting up in the air and figuring out where do we go now. So this type of planning in 2026 is, for me, something I do with nearly all patients. All right, let's see if we can go forward still here. All right. Other technologies that we have coming in the future, one is augmented reality, one where we can actually either on a screen or goggles be able to see exactly where we want to be able to put implants and use that technology, kind of like virtual reality, to know exactly how we want to do the surgery. And then the newest, latest, and greatest thing is robotics. And so, just like many of you may have heard about robotic replacement for hip and knee, like we do at Stoughton and many other places around, um, you know, we're getting to that point where the next frontier is using robotics for shoulder replacement surgery as well. And that's really exciting. I've been able to take a look and try some of this technology, and it's really impressive, and it's really going to kind of change the future of how we do our shoulder replacement surgery and really improve our accuracy. So I'm really excited about seeing this. So if we do talk about one of these surgeries, and say a patient has elected to move forward, the questions that patients have to ask always is that, are they healthy enough to undergo surgery? Ultimately, most shoulder surgeries we do are elective in nature. And because of that, we want to make sure that we have healthy patients we're doing surgery on. The last thing anybody would want is a patient to have a medical complication um, from having shoulder surgery. And so patients need to be healthy. They need to be optimized. The other thing that we talk about many with many patients is making sure they have adequate help. There's going to be a period of time where a patient after a shoulder replacement, maybe being in a sling for 4 weeks, and a rotator cuff repair, potentially being in a sling for anywhere from 2 to 6 weeks, they're not going to be able to do a lot of things by themselves, whether that be making meals, getting themselves dressed, getting bathed, getting in and out of a car. And so it's really important that we talk to patients about engaging friends and family to help them out throughout the process. That includes also getting rides to physical therapy because they may not be able to drive for the first couple weeks. And so these are all the things and considerations that we always talk to patients about, just to make sure that we're covering all our bases and making sure that we're making good decisions for our patients in terms of deciding if surgery is the right answer. So for rotator cuff surgery, what to expect? Usually, this can be done at a hospital or an outpatient facility like a surgery center. And like I said, in 2026, that's going to be mostly done arthroscopically at most centers. Usually takes about an hour to do the surgery, and patients will go home the same day. Yep. So we'll cross out open repair and mini open repair. Shoulder replacement surgery, same kind of thing, can be done in a hospital. And now many times we're performing that on an outpatient basis, meaning patients go home the same day from shoulder replacement surgery. You have an incision on the front of your shoulder, usually 4 to 6 inches long, and the surgery takes about an hour and a half, and patients go home the same day. What makes going home the same day a real possibility for both shoulder replacement and rotator cuff surgery is the anesthesia component. It's just not only our techniques, but the nerve blocks that we use these days can really help. Where potentially we have a patient whose shoulder is numb for about 48 hours. So for the first 2 days, they really don't have much pain. And the hope is that by having a nerve block that can last 48 hours, that by the time it wears off, that they're past the worst part of the pain. And that way, then they kind of have a little gentler landing and something they can control with medications. Physical therapy is a big part of the recovery. I could do the best surgery in the world, but if a patient doesn't participate and own the physical therapy component, we can have a less than ideal result. So it's really, really important. Um, and therapy is usually done as an outpatient, but it involves a lot of exercises that are done at home on your own. I tell patients therapy is like piano lessons. You don't get good going to the lesson, you get good by practicing at home. Recovery time varies based on patient to patient and what surgery it is. but somewhere 3 to 6 months can be full recovery where you're able to do everything you want. Now, outcomes can vary by patient, but the main goal is to help decrease and eliminate pain, restore mobility, um, restful sleep. That's a huge thing for most patients. If they're able to, sleep, period, and then sleep on that side where they have shoulder issues, if they're side sleepers, that's really, really big for a lot of patients. And then obviously return to their daily tasks and activities, and then return to doing the fun things they like doing, especially with friends and family, the things that really bring them happiness and joy. Patient satisfaction for both rotator cuff surgery and shoulder replacement surgery are very high, and I think they're some of my happiest patients are the ones who get shoulder replacements. All right. Success factors specifically for rotator cuff repair, obviously the quality of the rotator cuff, the quality of the bone, the conditions of the other muscles of your shoulder, and a patient's overall health, as well as their commitment to therapy, are all going to be important factors. So there's a lot of things that go on that are important. Some is what a patient brings to the table. Some is obviously what I'm able to do to help them. And the last part is their commitment to really um, doing their best in terms of helping their recovery afterwards. So the main point is that you can have pain, but you don't have to suffer, and there are many treatment options. Obviously, the cornerstone of everything that we're always going to recommend first is: are there ways that we can take care of these problems without having to do surgery? If we can achieve that, whether that's through rest, physical therapy, injections, medications, then that is going to be obviously our first option. But in cases where that may not work, or it hasn't worked after a certain period of time, then surgery can definitely be something that can be discussed. All right. Well, that's all I have. And thank you very much.
Thank you. So, Dr. Rawal, do you want to open up the chat and read them,
Yeah.
or do you want me? I can read them to you. There's
Yeah, I
just
can
one
open the
more.
chat here. Yep. And
Okay,
I
perfect.
correct me if I'm wrong, but I'm
What's the
not
question?
seeing any yet. But we encourage
Um,
people, if they have questions, they can type them in.
let's see. Well, I'm going to read them to you.
Okay.
So Laura has a good one. Could someone with a frozen shoulder have the in-space balloon spacer?
Um, Frozen shoulder is not is not one of the diagnoses we would do in-space balloon shoulder for. The in-space is really for people who have a rotator cuff tear that can't be repaired. Now, if someone has a frozen shoulder in addition to a torn rotator cuff that can't be repaired, then um, it potentially can be part of that. But I think I would probably need to know a little bit more information about specifically the frozen shoulder. But if we're saying the only diagnosis is frozen shoulder, then no, the in-space balloon would not be the right answer for that.
Okay. Can you speak about impinged shoulder and bursitis?
Yeah. So shoulder impingement and bursitis is it's kind of on the spectrum of kind of the early things that we see before maybe potentially someone develops a rotator cuff tear. And so early on, what we'll see, and as we kind of get into our 40s, um, the muscles around our shoulder blade weaken, our posture tends to get worse. We're over a keyboard or etc. And so with that, what tends to happen is our shoulders go forward, they get rounded, and then the roof of our shoulder um, hangs lower and lower, and then it doesn't give any room for the rotator cuff. So it's kind of like cutting it off, and patients will then develop bursitis, which is the bursa sac in that space gets inflamed, but then also that that bone rubbing against the rotator cuff will cause irritation of the rotator cuff, causing impingement. And so the first line treatment for many patients is to really work on the strengthening those shoulder blade muscles and to improve their posture. So instead of like this, we get exercises to get people back like that, and then create room for the rotator cuff to breathe and not be kind of stuck and impinged in there. But if it goes on for a long period of time with that impingement, that can be the factor that can then start leading people to have a tear of their rotator cuff. And so it's kind of a spectrum. And so many times, if we see patients with impingement that we can try to help and address sooner, then maybe they don't get to that point that they potentially tear their rotator cuff and need treatment for that. But that is something that, again, initially for all impingement bursitis, a lot of conservative treatment, therapy, injections, etc. And it can resolve. And I can attest to that. I've had bouts of impingement myself, and diligently doing the exercises, um, things got better on their own.
That's the key. I hear you say diligently doing the exercise.
Right. Yeah.
Someone else came back and asked, what is frozen shoulder?
Yeah, great question. So frozen shoulder is a condition where the lining of your shoulder, the capsule, becomes inflamed. Um, and when it becomes inflamed, it gets really thick and stiff. So imagine on my shirt here, it is loose enough that I can move my shoulder in every which way. Now, with a frozen shoulder, imagine if I took this and I tightened it here and then I tightened it in the back. Well, now I can't move around. And that's what frozen shoulder is. Now, we don't know necessarily what causes frozen shoulder. The most common type we see is what we call idiopathic, meaning we don't know why. Other sources can be traumatic, meaning maybe from a fall or an injury, someone can develop frozen shoulder as well. We know that we see it twice as more common in women than in men. It's most common in people in their 50s and 60s. Um, the positive thing is that for most patients, 90% plus frozen shoulder will get better over time on its own without needing any surgical intervention. If we leave it alone and don't do anything, it can take 12 to 18 months to completely resolve. We know that if we see patients and evaluate them, and whether therapy, injections, medications, we want to shorten that. We want to make this a 6 to 9 month thing rather than a 12 to 18 month thing. Um, and so, and the other thing we know in terms of data is if you get it in one shoulder, you have about a 20% chance of getting it in the other shoulder in the next 18 months. So if you get it in one, you may get it in the other. One thing I've not seen is that once someone has frozen shoulder, I've not seen them get it like a second time. So I don't know, maybe it's kind of like chicken pox, because one of the theories is that it may be secondary to a virus, that we get it. Um, we're not sure. No one's ever figured that out.
Can you talk about nerve injuries in the shoulder?
So nerve injuries that we usually see in shoulders happen from traumatic reasons. I think that's what they're addressing, versus I don't know if they're talking about nerve injuries that happen during shoulder surgery, which is uncommon but possible. But ones that you can get from injuries, if someone has a shoulder dislocation where the ball side, dislocates out of the socket, that can cause stretching of nerves, and that's usually temporary in nature. We'll also see nerve injuries from people who fall and get fractures. That can also cause that. And luckily for those, again, those are temporary in nature. The nerve will go to sleep, and over time, the usual rule is it does recover. It may take time. It doesn't happen 100% of the time that it recovers, but most times it will recover.
Can you speak about calcium deposits? This person's had lavage and steroid, but the pain is back. Does it imply new calcium deposits?
Yeah, so calcific tendonitis is a condition where you can have calcium deposits that either sit on top or within your rotator cuff, and it can be very painful. The treatment for that usually is non-surgical. Many times with medications or injections, patients will improve. We also can have them sent to radiologists who, under ultrasound, actually can basically break up the calcium deposits. And once they kind of break up, they go away. But sometimes we do surgery for those when it recurs for patients or they're really large deposits. What can happen is they can also then lead to patient having a rotator cuff tear. And it's that rotator cuff tear part that we're addressing more. And yes, we remove the calcium deposit at the same time.
And how is ligament laxity addressed?
Can you repeat that again? Ligament
Ligament
laxity.
laxity.
And what was the question about?
It just says how is ligament laxity addressed?
Oh, okay. So there's different types of ligament laxity. Some people are what we call hypermobile and have a lot of just looseness in their shoulder. That we tend to see with younger people. It tends to resolve as we age. Um, but sometimes those loose ligaments early on, again, conservative treatment with therapy, etc., is our first line option. But in the right patient who is ligamentous lax, we definitely do surgery to tighten up those ligaments to then restore that stability for patients, and it can really be life changing for them because their shoulder feels unstable all the time and they're not able to do many activities.
Well, I'm happy to say we hit 6:30. We covered all the questions. Thank you
Yeah, those are
for,
great questions.
yeah, I was going to say thank you for the great information, and I want to shout out to the group. Those were really, really good questions. So if anyone wants to reach out to Dr. Rawal at the OrthoTeam Clinic, please do. You can go to stoughtonhealth.com and that'll link you. Otherwise, thank you again, and I wish
Yeah,
everyone
thank you, everybody.
stay warm.
Thank you.
Bye.